Hello doctors. Today we are going to cover another pediatric surgery topic, that is the deformities of the chest wall part 1. The deformities of the chest wall, these are the musculoskeletal disorder of the anterior chest wall. Most are not life threatening and main impact is an psychosocial well-being. Main impact which happens is on psychosocial well-being. Sometimes the chest wall deformity rarely causes dyspnea, cardiac dysesthesia and limited walk performance. In some patient, most of the patient, they do not have any kind of symptoms, only it is cosmetically it looks bad. And few of them have restrictive lung diseases, that are total lung capacity decreases and the vital capacity of the lung decreases. So we have the classification for the deformity of the chest wall. That is, number 1 classification is modified A Castello classification of the chest wall deformity. Modified A Castello classification have 4 types: type 1, type 2, type 3 and type 4. Starting with the type 1 is cartilaginous. Cartilaginous and most common chest wall deformity is pes excavatum. Most common is pes excavatum. That is, what is pes excavatum? When there is depression in the chest wall. When there is depression in the chest wall, that is known as pes excavatum. And second is pes carinatum type 1. Carinatum means there is protrusion in the chest wall is present. That is known as pes carinatum. It has 2 types, type 1 and type 2. We will see in following parts what are they. And the type 2 is costal type. The costal type can be divided into 2, that is simple rib and complex. In simple, only 1 or 2 ribs are involved. There may be agenesis of ribs or hypoplasia or bifid ribs may be present. And in complex situation, there are more than 3 ribs are involved. The more than 3 ribs are involved, they are involved with associated syndrome, that is Genu syndrome, Charcot-Levin syndrome and cerebroasthenomandibular syndrome. And type 3, this is important because it has came in MCQ in NEET SS previous year. In type 3, the costochondral abnormality or deformity is present and it is known as Poland syndrome. And what are the components involved in the Poland syndrome, we will see in the following videos. Then we have type 4, that is the sternal type. In the sternal type, there is presence of sternal cleft and Currarino-Silverman syndrome. This is one classification. Remember the name, that is modified A Castello classification. We have another classification. This is the first. We have second classification. 2 classifications are there only. That is Villitel's classification. In Villitel's classification, it is easy. It seems complicated but easy. It is easy. Type 1 is symmetrical funnel chest. What do you mean by the funnel chest? Funnel chest means pes excavatum. There is insertion, there is cup-shaped chest. Funnel chest, otherwise the thorax is normal, or there is asymmetrical funnel chest, otherwise thorax is normal. The type 1 is 45%. This is the most common type. And second most common is asymmetrical funnel chest, otherwise normal thorax. This is second one. This is the second most common. This is the most common. And this is the second most common. Fine. Now, type 3 is symmetrical funnel chest and platithorax. Platy means flat thorax, and asymmetrical funnel chest and platithorax. This type 1, 2, 3 and 4 in Villitel's classification is correlates with the pes excavatum. These are the different types of pes excavatum, which is we have seen in the modified A Castello classification. This pes excavatum is further here in Villitel's classification is mentioned as type 1, 2, 3 and 4. Now type 5 is symmetrical pigeon shaped. What is pigeon chest? Pigeon chest means there is protrusion in the chest, and pigeon chest is equal to pes carinatum. Symmetrical pigeon chest, otherwise normal thorax. Type 6 is asymmetrical pigeon chest, otherwise normal thorax. Type 7 is symmetrical pigeon chest with platithorax and asymmetrical pigeon chest with platithorax. These are only 2 or 1%. Like pes carinatum is very rare, only in 1 to 2%. And 9 number, this 9 number is combination of both. There is depression in the chest, funnel chest, or protrusion of the chest. Both are present, and it is present in only 2% population. So from type 1 to type 9, all of these are type 1 cartilaginous in A Castello classification. A Castello classification, these all are either pes excavatum or pes carinatum or combination of both. So these all fall under type 1 of A Castello. Now type 10 is aplasia of ribs. Ribs means costal involvement is there, with which correlates with the type 2 of A Castello classification, and type 11 is manubrium sternal cleft, which is type 4 of A Castello classification. Here in the image, one by one we will see. As I have said, this is pes excavatum. Pes excavatum, here is depression in the chest wall, as we can see. This is pes excavatum. Type 1 to type 4 is pes excavatum, which is 86%. 86% most common type is pes excavatum. Now this is pes carinatum. Pes carinatum is from type 5 to type 8. It is seen in 8% of the individual, and either it is combined. Here there is protrusion like pigeon chest is also present, and funnel is also present. So this is combination of both pes carinatum and excavatum, which is present, which is type 9, which is present in 4% of the individual. Now we will start with the pes excavatum, which is the most common type, which is seen in 85 to 86% of cases. So first, incidence. Incidence of pes excavatum is 1 in 1000. Fine. And male is to female ratio is 3:1. And this is also known as funnel chest. Pes excavatum is also known as funnel chest or thorax and entonoir or Trichter bust. The vast majority are familial and sporadic. Both pes excavatum is autosomal dominant, and there is sternal depression associated with malformation of, it is associated with malformation of lower costochondral joints. Costochondral joints. Most common, accounting for 90% of chest wall deformity, as I have said, and it is more common in white people. All over the ratio is 1 in 1000, but in white people the ratio is 1:300. Boys are 3 times more affected and manifest soon after the puberty growth spurt. Now what is the etiology? Etiology is still non-specific. We don't know exactly. Sometimes it is also known as because it happens because of deficiency in vitamin and nutrient. Vitamin and nutrient deficiency. It might occur in cases of disorders of connective tissue. And it might happen because of genetic predisposition, overexpression and downregulation of, either overexpression or downregulation of matrix metalloproteinase. Or because of collagen genes, or tumor necrosis factor alpha, or filamin. And familial occurrence is approximately 40%. Sporadic, rest are sporadic, but familial is also 40%. You have to remember here either overexpression or downregulation of matrix metalloproteinase. This is asked many times in MCQ. Now, what are the clinical features? The clinical features, most of the cases are mild during infancy and progress with age and manifest during the pubertal growth spurt. Cosmetic concern, mostly the patient are asymptomatic. Only they have cosmetic concern. Deep sternal depression sometime causes, if there is deep sternal depression is present, then deep sternal depression causes respiratory and cardiac symptoms, sometimes, rarely. What are the respiratory symptoms? The respiratory symptoms are dyspnea, then lack of stamina, and thoracic pain. And what are the cardiac symptoms? The cardiac symptoms are, they have mitral valve prolapse, left shift of heart, and compression of right ventricle. So these are the features, cardiac symptoms that are present. And in PFT, if we do the pulmonary function test, in PFT we have the restrictive pattern. And I have mentioned earlier also, they have decreased vital capacity and decreased total lung capacity. In cosmetic disfigurement is also present, and 50% milder degree of scoliosis and kyphosis. In 50% of patient, we can see milder degree of kyphosis or scoliosis. Fine, in 50% of patient. Now classification. We have in pes excavatum, we have 8 morphological variants. Number 1 is saucer type, which is most common type of pes excavatum, which means flat thorax. This is known as saucer type. Now, second we have Grand Canyon type. What is Grand Canyon type? Grand Canyon type means deep and severe excavation with long tunnel in the sternum. Like over the chest, we can see there is a presence of long tunnel is present. This is Grand Canyon appearance. Number third, it may be punch type, or is it also known as cup shaped. It may be transverse, eccentric, and pes excavatum with flaring chest. Type C is pes excavatum with flaring chest. This type mimics rickets. And there may be type 7, there may be compound pes excavatum or superior pes excavatum. So these are the 5 morphological variants. Saucer type is the most common, Grand Canyon type, punch shaped, cup shaped, transverse, eccentric, pes excavatum with flaring chest, which mimics the ricket, and compound pes excavatum, and the superior pes excavatum. Now how will we diagnose this case? Evaluation of the shape of the excavatum is important to selecting the right surgical approach. So for diagnosis, we have one index that is known as Haller's index. What is Haller's index? Haller's index is transverse thoracic diameter, transverse thoracic diameter. We have the transverse thoracic diameter divided by the anteroposterior diameter. If it is more than 3, then pes excavatum is of course present. Apart from that, patient needs surgery. So diagnosis mainly it defines whether the patient should do given surgery or not. Now management, you have to remember in diagnosis the Haller's index. Apart from that, in management, the age of correction is approximately in 9 to 15 years for Nuss procedure. What is Nuss procedure? I will tell in this video as this video goes on. And below 8 years, why 9 years? Because if we do correction below 8 years, more below or equal to 8 years, then it has been seen that there are cases of severe cardiopulmonary compromise. One is this, because later on their lung will grow in size, heart may grow in size, so later on they have severe cardiopulmonary compromise. Apart from that, if we do correction in less than equal to 8 years, then recurrence happens, high chances of recurrence, and Johannes syndrome. Johannes syndrome is asphyxiating thoracic deformity happens. Therefore, age of correction is 9 to 15 years. Fine. Now treatment. What are the treatment? Symptomatic pes excavatus or pectus excavatus with respiratory, cardiac and psychological. So treatment is given, like surgery is given for the patient, those who are symptomatic. Either they have respiratory symptoms or cardiac symptoms, they should undergo operation. Number second, I have already mentioned, when Haller's index is more than 3 or 3.25, you can say, then patient needs operation. Number fourth, when there is decreased stroke volume because of cardiac compression, then you need to do operation, surgery. Number fourth, when there is compression of vena cava or pulmonary veins, at that time. Number fifth, significant restrictive pattern in spirometry. In spirometry, there is restrictive pattern. Then in cases of paradoxical chest movement, and it is also done in cases of where they have failed previous operation, some surgical operation was done which was failed, then we have to do it again. And if there is progression of deformity is worsening day by day. So these are the 8 causes in which you should do surgical correction in cases of pectus excavatus. Now there are 2 surgery. One is Ravitch procedure, another one is Nuss procedure. So what is Ravitch procedure? Ravitch procedure is excision of the deformed costal cartilage. Excision of deformed costal cartilage. The costal cartilages, generally the lower ribs are deformed more, and here we do preservation. So there are 2 surgical procedures for this. One is the Ravitch procedure, which I have said. The Ravitch procedure is excision of the deformed costal cartilage. This is the deformed costal cartilage which is removed, but we preserve the perichondrium. This is the perichondrium. If we preserve the perichondrium, what is the advantage? If we preserve the perichondrium, then we will allow to regenerate these ribs, and after this the sternum will be free. Either the sternum is excised out or sternum is fixed with steel bars. So if we see the procedure in short, the costal cartilages are excised out, then sternum is pulled anteriorly. Either it is fixed or sternotomy may be needed, and sternum is fixed by using steel bars. And there is one Wada's modification of the Ravitch procedure. The Wadha's modification is the whole sternum is taken out, then it is rotated 180 degree and fixed again. The sternum is rotated 180 degree and fixed again with the costal cartilages. This is the Wadha's modification. What is the Nuss procedure? Nuss procedure was introduced in 1998. And what is the difference between these two procedures? In Nuss procedure, there is no excision of the any kind of the ribs are done. There is no osteotomy, no costal resection. Instead of that, either we use generally one steel bar and sometimes we use two steel bar or nickel are majorly used and for fixation of the chest. And this nickel bar, before introducing the nickel bar in the chest, you have to test the allergy test whether the patient is allergic to the nickel or not. And what are the complications of these two surgical procedures? One is most common wound infection. There may be bar dislodgement, pneumothorax, hematoma or major bleeding. In young patient, there may be floating sternum or Juane syndrome. And in specifically Nuss procedure, there may be pericarditis, hemothorax and nickel allergy. Thank you for watching today's video, guys. We will continue with the part 2 of this video where we will cover POSTGRADUATE and all the other subtypes of the classification like Poland syndrome and costal complexes and the sternal deformities. Thank you for guys, and please do like